Welcome to this series of lectures in oral medicine, this one entitled Oral Manifestations of Systemic Conditions. This will form a general overview of conditions that can present in the mouth, and you will need to supplement this with previous module material. This lecture will basically cover a myriad of conditions systemic conditions that can have an impact on the oral cavity. However, we will break it down into some more common ones that I will discuss towards the end of the lecture. So as listed in this slide, there are, as you can see, that there's a multitude of different conditions that can have an impact on the oral cavity and manifest in various ways. However, it's not expected that you will know all of these conditions and how they affect the oral cavity. But we might basically just focus in this lecture on the topics in black. So if we talk about muco, and then I have given you information on some of the other conditions on this slide, which you have as lecture notes, and if you read through that for your own benefit to get an understanding of what some of those conditions are. So if we go back to the conditions that I have highlighted in black, amyloidosis represents a heterogeneous group of conditions leading to the deposition of amyloid, which is a proteinaceous substance, and it's organ limited and occurs rarely in the oral cavity. Systemic amyloidosis, the primary variety is myeloma associated, so it affects adults mainly and causes weight loss and fatigue, hoarseness of the voice, and macroglossia. So an enlarged tongue is a sign that in the oral cavity of amyloidosis. Secondary amyloidosis can occur following hemodialysis associated or hereditary familial cause. Vitamin deficiency, we know that vitamin A can lead to blindness and skin dryness. Thiamine deficiency can cause peripheral neuropathy and neurologic problems. Riboflavin causes glossitis, angular cheilitis, sore throat, swelling and erythema of the mucosa. Niacin again causes glossitis. Vitamin C deficiency, also called scurvy, can cause delayed wound healing, gingival swelling and hemorrhage, and ulceration. Vitamin D, rickets in infancy and osteomalacia in adults. Mainly get it from dietary, milk and sunlight. Vitamin K will cause increased bleeding. Deficiency will cause increased bleeding. Iron deficiency, excess blood loss, can be due to excess blood loss, increased demands or decreased intake, or due to a decrease in absorption through gastrointestinal disease. Plummer-Vinson or Patterson-Kelly syndrome includes iron deficiency, glossitis, dysphagia, and an increased risk of squamous cell carcinoma. Gigantism, or due to increased growth hormone, may be caused by pituitary adenoma during the growth period. McCune-Albright syndrome, which causes polyostotic or many bones, fibrous dysplasia, cafe au lait pigmentation, brown discoloration, and endocrine disturbances. Acromegaly occurs through an increased growth hormone as an adult. So in these people you may get mandibular prognathism, spacing of teeth, an open bite in the occlusion, and macroglossia. Hypoparathyroidism, parathormone and vitamin regulate calcium levels in extracellular tissues. So a decrease in parathormone leads to hypocalcemia, which leads to failure of tooth eruption, pitting of enamel, persistent candidosis, endocrine candidosis syndrome. Addison's disease, we have discussed this in previous lectures. Hypoadrenocorticism causes intraoral brown macular pigmentation, which is basically an excess of melanin. Crohn's disease, which is an inflammatory immune-mediated condition affecting the small bowel, but can affect any part of the GI tract. And it causes malabsorption, leading to deficiencies that affect the oral mucosa, causing ulceration, as well as granulomas in the connective tissue of the mucosa. Piostomatitis vigitans, also we have discussed this in previous lectures, and affects the gingiva, similar to the pathogenesis of inflammatory bowel disease, appearing as yellowish white pustules on an erythematous broad base of the gingiva. Other systemic disorders such as HIV/AIDS, lupus, anemia, leukemia, acromegaly, diabetes, Crohn's disease, which we have discussed, tonsillitis, syphilis, tuberculosis, cat scratch disease, Paget's disease. These have been described in earlier lectures. Osteogenesis imperfecta, I expect that you have had that in development disorders of dentition. So if we talk about HIV/AIDS, one or more opportunistic disease diagnosed by reliable methods, which are at least moderately indicative of an underlying cellular immunodeficiency. So you must have absence of all other known causes of cellular immunodeficiency, absence of causes of reduced resistance known to be caused by these opportunistic infections, and they have to be HIV positive. Came to light in 1981, and by 1992, 8 million people were infected by HIV. Primary target is the CD4 positive helper T cells. On introduction of HIV, those infected will have acute self-limiting infection, symptoms similar to infectious mononucleosis, but lasting a few weeks, followed by asymptomatic stage, 8 to 10 years. Then you have persistent generalized lymphadenopathy, or swelling of the lymph nodes, AIDS-related complex, which is chronic fever, weight loss, oral candidosis, herpes zoster, oral hairy leukoplakia. Other oral manifestations include Kaposi sarcoma, which is associated with human herpes virus 8, trigeminal neuropathy, and xerostomia, or dry mouth. HIV is present in oral fluids. Saliva reduces the ability of HIV to infect its target cells. Anecdotal reports of HIV transmission from oral sexual contact, oral contact, and breastfeeding. So if we talk about oral manifestations of HIV, we talked about fungal, bacterial, and viral infections, as well as neoplasms, Kaposi sarcoma, lymphadenopathy, the cervical, which may lead to, and you might have neurologic manifestations such as trigeminal neuralgia, facial palsy, and other manifestations as well, such as aphthous stomatitis, necrotizing ulcerative gingivitis, and so on. So persistent generalized lymphadenopathy, which occurs for greater than 3 months and should involve greater than 2 extrainguinal sites, more than 1 centimeter in diameter, and third will have diagnostic AIDS within 5 years. So going on from HIV, we look at candidosis, which can also occur in AIDS. It's the disease of the diseased, which means immunocompromised people tend to have this more prevalent, often presenting signs that leads to diagnosis. Predictive for development of full-blown AIDS within 2 years. different clinical patterns. Pseudomembranous and erythematous are the most common. Esopharyngeal involvement implies that the patients have a poor prognosis. So here what you see is this erythematous patch in the palate and a white and milky area further back. Here this is a pseudomembranous candidosis in the pharyngeal region and white appearing tongue. HIV-associated periodontitis, what you see here is linear gingival erythema, doesn't respond to normal plaque control, necrotizing ulcerative gingivitis and periodontitis, as well as necrotizing stomatitis. So here we have necrotizing ulcerative gingivitis, ulcerative periodontitis, HIV-associated stomatitis, and linear gingival erythema. You can also get Kaposi sarcoma, which is HHV8 associated vascular neoplasm, and HIV associated hairy leukoplakia, and HIV associated herpes. Herpes simplex virus incidence the same as in general population, up to 10 to 15%, but the lesions are more widespread and occur in a more atypical pattern, may persist for months. Active infection for more than 1 month occurs in AIDS. Varicella zoster, herpes zoster, more severe course of infection, lacks dermatomal distribution. So here we have an example of herpes simplex virus infection and herpes zoster, varicella zoster. Oral hairy leukoplakia, distinct pattern of hyperkeratosis on the lateral border of the tongue. It looks hairy, white mucosal lesion that does not rub off, induced by presence of Epstein-Barr virus, usually associated with immune suppression or deficiency. And this is an example, a clinical photograph of someone that's got hairy leukoplakia. And again here, in this white patch. Kaposi sarcoma is a neoplasm of vascular origin, also affects trunks, arms, legs, heart, palate, and gingiva are the most common sites intraorally. Flat brownish or reddish lesion that eventually may develop into nodules. There will be pain involved and bleeding, progressive malignancy that can disseminate, and as mentioned previously, caused by HHV8. And here's an example of a large area of Kaposi sarcoma. And again, this recurrent aphthous stomatitis is clinically similar to RAS occurring normally, but with increased frequency in HIV patients. 2/3 have uncommon major herpetiform variety. It may not be RAS. It may also involve fungal or cytomegalovirus or neoplastic involvement. This is an example of a recurrent aphthous stomatitis, typical appearance of ovoid shaped erythematous halo, but a little bit more fiery. Human papillomavirus induces many oral lesions. The most common is the common wart or oral squamous papilloma, seen with increased prevalence in HIV patients. Again here you get this wart-like cauliflower appearance of the lesions. HIV-associated salivary gland disease. The main sign is gland enlargement. Parotid gland is the most common. Decreased production of saliva can occur and cyst formation is present. Lymphoma, aggressive malignancies that can appear anywhere. 3% of HIV positive people, 60 excuse the interruption. Anyway, back to lymphoma. What you have is aggressive malignancies that can appear anywhere, present as nodal soft tissue enlargements. And here you can see the enlarged gingiva of a lymphoma patient. Lupus, systemic lupus erythematosus involves skin mucosa and other areas of the body. People may fever, fatigue, weight loss, lymphadenopathy, debilitation. And 30 to 45% will show oral lesions, which are painful erosions or ulcers surrounded by a reddish or white zone, palate, lips, and buccal mucosa. Also petechiae, xerostomia, dry mouth or hemorrhage may occur. And here's an example of lupus lesion of the lip, upper lip. Anemia may cause iron deficiency, may be caused by vitamin B12 deficiency called pernicious anemia. Tongue changes are the most obvious. Depapillation and progressive smoothing of the tongue surface may lead to a burning sensation or loss of taste. Here's another example of vitamin B12 deficiency showing up as a tongue lesion. Leukemia, which is a malignancy of white blood cells, many different types, each with varying prognosis. Spontaneous hemorrhage of the gingiva often is a presenting sign. The ulcers and bacterial infections and periodontitis may also occur. Again, an example of this foggy gingiva. Acromegaly occurs as an excess production of growth hormone after closure of the epiphyseal plates. So in adulthood, most common cause is functional pituitary tumour, enlargement of small bones in hands and feet, mandibular prognosism, and coarse facial features. Here's an example again of this. Crohn's disease, which occurs in the 20 to 30 age group. Abdominal pain, diarrhea, weight loss, vomiting, rectal bleeding may occur. Oral lesions occur in up to 20% of the patients. And what you see is a granulomatous change in the buccal mucosa often. So the granulomas occur deep in the connective tissue. The surface mucosa may show a cobblestone appearance or presence of mucosal tags. There may be persistent lymphadenopathy, non-painful, and regress when the intestinal symptoms subside. Tonsillitis, you can have a bacterial or viral cause. Streptococcal bacterial infection is the most common in 25%. What you have is a sore throat, fever, and dysphagia. Hyperplastic tonsils may be present. Yellow tonsil exudate, as seen in these enlarged tonsils in this picture. Syphilis, complicated with 3 distinct stages. Treponema pallidum is the causative agent, as mentioned in the infection lecture. You may have primary or secondary lesions, secondary being the mucus patches or snarl tract ulcers, and then the gummer as a tertiary lesion, bearing in mind or remembering that congenital syphilis may cause Hutchinson's incisors and mulberry molars. And these are the snarl tract ulcers. TB, tuberculosis, chronic infectious disease, lung type most well known, but lots of other types. Area of infection is called a tubercle. Chronic ulceration and granularity is a presentation that can be seen. Gingiva and mucobuccal fold. Secondary lesions, tongue, palate and lip. And here again, an ulcer on the tongue of a TB sufferer. Cat scratch disease, again, this has been discussed in the infection lecture, begins in skin, travels to adjacent lymph nodes. Swelling of the affected node may be intraoral, usually submandibular where the face has been scratched. And again, you get this lymphadenopathy. Paget disease, which is the abnormal resorption and deposition of bone, distortion and weakening of the affected bone. On radiographs, you may see a cotton wool appearance. Jaw involvement occurs in about 17%, and during the active phases, the bone is very vascular. So these radiographs of the hip area and the skull show the multiple cotton wool radiolucencies. Cleidocranial dysplasia, defective bone gene, clavicles either malformed or absent. The patients generally have a long neck and narrow shoulders, short stature, pronounced frontal and parietal bossing, narrow high arched palate, prolonged retention of deciduous teeth, failure or delayed eruption of permanent teeth, distorted crowns or root shapes and supernumeraries. So they can bring the shoulders together often, and you see that there's those abnormalities seen. Sorry once again for that interruption. Anyway, as seen, you can see the abnormalities in cleidocranial dysphagia. Osteonecrosis of the jaws, ONJ. Osteonecrosis of the jaw may occur as a result of radiation-related damage. High risk of ONJ following bisphosphonate therapy, but also other drugs now. So in the past we used to call it bronze or bisphosphonate-related osteonecrosis of the jaws, but that term should be replaced with drug-related drug-related osteonecrosis of the jaws. Bisphosphonates are used for treatment of osteoporosis, multiple myeloma, Paget's disease, and chronic bone pain. There have been cases of other medications, as mentioned, and DRONJ should be the term that will become available in the future. Other manifestations, immune-mediated vesicular bullous disorders such as pemphigus, pemphigoid, and lichen planus, as well as erythema migrans, lupus, erythema multiforme, can cause oral ulceration and other manifestations. Dermatological disease such as white sponge nevus, Peutz-Jeghers syndrome, Ehlers-Danlos syndrome can also cause oral or perioral lesions, and allergies such as drug reactions. Peutz-Jeghers syndrome causes freckle-like lesions of the hands and perioral and oral mucosa. There's intestinal polyposis, and these polyps have a predisposition to developing cancer. Ehlers-Danlos syndrome, a group of inherited connective tissue disorders where the classical type, you have a defect in collagen type 1 and 5, and what you get is hyperelasticity of the skin, cutaneous fragility, and hypermobility of joints. Thank you very much.